Bismillah ar-Rahman ar-Rahim. I'd like to thank at first Professor Amal Bishlawi for her kind invitation for the conference. I'd like to thank my Professor Dr. Muhammad Talat, Dr. Ali Abdulaziz. Today I'll talk about iron overload in thalassemia patients, pathophysiology and management. My agenda. First, I'll talk about introduction. Thalassemia, as many of my professors talked before, it's an inherited disease with multiple genetic forms, ranging from alpha, beta thalassemia, hemoglobin E beta thalassemia, and many other genetic forms. Molecular defects usually cluster in two types of chromosomes, chromosome 11 for beta globin gene defects, and chromosome 16 for alpha globin gene defects. Thalassemia disorder lie on a spectrum of severity with different clinical phenotypes, complication, and strategies of treatment. In our clinical hematology clinic, since 2018 till 2021, we have 180 cases of thalassemia following regularly with us. 66% of them were thalassemia major, and 18% were thalassemia intermediate, 16% were thalassemia minor. What about the pathophysiology of iron overload in transfusion-dependent versus non-transfusion-dependent thalassemia? Also, this picture we have seen before describing the pathogenesis of thalassemia occurring in the case of transfusion-dependent thalassemia mainly. Usually, the main problem in thalassemia is the reduction or the absence of beta globin chain, which leads to imbalance between beta and alpha globin chain synthesis. That's the hallmark of thalassemia syndrome as a whole. This will lead to precipitation of RBC's precursor within the bone marrow, premature death of RBC's precursor, leading to ineffective erythropoiesis, and membrane damage to peripheral red blood cells causing hemolysis. Both will cause anemia. That will lead to erythropoietin production, increased production, causing complications, skeletal deformities of thalassemia, and will lead to increased iron absorption in the intestine. Also, this will require blood transfusion to overcome anemia. Both blood transfusion and the increased iron absorption will lead to iron loading in tissues, liver, endocrinal organs, and myocardium, causing complication. The image shown describing the pathophysiology mainly in non-transfusion dependent thalassemia, which describes an interplay of many factors that present in a non-transfusion dependent thalassemia patients on a base with a base of a chronic tissue hypoxia and a hypercoagulable state that's evident in non-transfusion dependent thalassemia patients, together with many other factors like the hemoglobin F levels, splenectomy case, the age of the patient, the condition of transfusion, the condition of chelation, and the gender of the patient. What are the causes of iron overload based on thalassemia type? In case of transfusion-dependent thalassemia, the main cause we are fronting in transfusion-dependent is the lack of physiological mechanism that clears iron from the excess iron from the circulation. Each unit of transfused blood adds to the circulation about 200 to 250 milligram elemental iron. The transfusional iron usually amount from 0.3 to 0.6 milligram per kg per day. If we assume that the patient is transfusing from 2 to 4 units packed red cells monthly. This image is showing what occurs after the transfusion of a red blood cell. When transfusion of a red blood cell unit occurs, what happens? Absorption and phagocytosis of the red cells, transfused red cells will occur by the reticuloendothelial phagocytes. Then the cellular iron will be released in the circulation. The transferrin, which is the iron bound protein, will bound to all the amount of iron it can bound to. Then the excess iron will be released in the circulation and then transported via the calcium channels to enter the cells in the liver, in the myocardium, and in the endocrinal organs, leading to the many cellular problems that occur as a result of iron overload that causes infection finally, fibrosis, neoplasia even, and finally cell death. What about non-transfusion dependent thalassemia? Increased intestinal iron absorption second to ineffective erythropoiesis is the main mechanism of iron overload in non-TDT, together with hepcidin suppression and erythron expansion. It's to be noted that every 1 milligram dry weight increase in the liver iron concentration is associated with increase in risk of thrombosis, pulmonary hypertension, hypothyroidism, osteoporosis. All the complication occurs in non-TDT. Patients with iron overload in case of non-TDT has a higher risk for developing also renal dysfunction. Back to our patients, we have 66% of our patients TDT and 33% were in TDT with a mean ferritin level 2020.23 nanogram per ml. Regarding complications of iron overload, why complications occur in thalassemia? It occurs due to deleterious effect of profound anemia, intramedullary and extramedullary expansion, rapid iron turnover, and tissue deposition of excess iron. Complications of iron overload variable between transfusion dependent and non-transfusion dependent. Here we found that both types of thalassemia affected by endocrinal manifestations, endocrinal complications, however, we have other complications that affect mainly the transfusion dependent thalassemia, like the cardiac siderosis, arrhythmia, heart failure, liver fibrosis, liver cirrhosis, up to the development of hepatocellular carcinoma. In case of non-TDT, there is venous thrombosis, leg ulceration, and silent strokes. Cardiac complication, the incidence of heart failure in TDT patients decreased due to the advances in MRI imaging, which allowed us to discover the iron overload status very early and the availability of iron chelators with improved adherence of the patient too. Actually, the complications are cardiac complication variable between arrhythmia and AF with the high incidence of AF. Cardiac function changes due to the occurrence of restriction, fibrosis, arterial changes due to loss of vascular compliance as a complication of prolonged iron overload without treatment. Symptomatic arrhythmia in thalassemia patient represent a significant clinical risk, and it usually reflects a significant myocardial iron overload. It can occur in patients with normal iron level, but this reflects that there is a fibrosis in the myocardium due to past iron deposition. How frequent should we check for cardiac condition? Usually annually for all patients, biannually in asymptomatic patients with abnormality, monthly or more frequently in symptomatic patients assessment. Assessment usually by ECG, by echo, or by cardiac T2 star, or MRI measurement for cardiac fibrosis. We have performed a study in our clinic, included 35 adult thalassemia patients who performed the iron overload status and assessed the patients by echocardiography and by MRI T2 star over the myocardium, and we discovered that there is a clinically significant p-value when compared the diastolic dysfunction and the cardiac MRI T2 star results. Also, there is a clinically significant p-value when comparing the cardiac MRI T2 star results and the history of using iron chelating. Pulmonary hypertension, one of the important complications that occur primarily in the NTDT patients and occurs also in TDT patients that are suboptimally treated. Also, there is other risk factor in thalassemia when the platelet count is more than or equal to 500,000, or the hemoglobin level less than 9, or there is a history of thrombosis. Usually the patient, we have to have a close eye on it. If he may develop a pulmonary hypertension. If he has a confirmed pulmonary hypertension, we should refer to a specialist, and they may benefit at this time with blood transfusion, hydroxyurea, sildenafil, adequate control of iron overload, and anticoagulant therapy. Regarding hepatic dysfunction is a lead cause of mortality in TDT, and it's responsible for 10% of the mortality in non-TDT patients. Chronic hepatic iron deposition promote hepatic fibrinogenesis and cirrhosis in both TDT and non-TDT. There is a higher risk for significant fibrosis and cirrhosis. Overt morbidity primarily manifest in older adults. We have an interplay between the occurrence of iron overload and the presence of an underlying hepatitis C that had an increased incidence with the repeated fibrosis. Both increases the incidence of the development of hepatocellular carcinoma in patients with thalassemia. What about endocrinal complication? Growth retardation, skeletal deformity attributed to ineffective erythropoiesis, medullary expansion, and anemia. Prevalence of diabetes وhypothyroidism وhypobara وhypogonadism وadrenal insufficiency. كل دول remain considerably high with high incidence, particularly in both patients, whether transfusion or non-transfusion dependent. We may have other underlying etiologies, including the splenectomy, the hemoglobin status. So we may have other underlying etiologies for the occurrence of endocrinal abnormality. We have screened our patients, 60 of our adult thalassemic patients for the occurrence of endocrinal manifestation. We found that 56% of them have hypogonadism, 58.8 of them have high short stature, 12.8 have glycemic abnormalities, 5.8 have hypobara, and 3.9 have hypothyroidism. What about the diagnosis and monitoring of iron overload? Usually, we are performing, all of us in our clinic, the most simple way for the follow-up of the patient, which is the serum ferritin. It has advantages and disadvantages. The advantages is it is easy to be evaluated and expensive. Serial measures available positively correlates with morbidity and mortality. However, it has a major disadvantages. It's indirectly measure the iron burden, fluctuates in response to inflammation, abnormal liver function. Also, individual measure may not accurately reflect iron level and response to chelation therapy. So we have other measures to detect or to estimate the iron overload in the liver and in the myocardium, including biopsy in case of liver iron assessment, squad weigh, and MRI T2 star. Actually, if we compare the MRI T2 star with the liver biopsy, MRI is superior for liver biopsy for the detection of iron overload. Why? Despite that the biopsy is giving us the information of the histopathology of the cells and giving us an accurate way for detection of iron overload, it's an invasive way. So we cannot apply it for all patients. However, the MRI T2 star giving us an accurate results, it's not invasive. It's superior now, and it's used by most guidelines now for thalassemia management as a reliable method, and it's correlated directly with the iron overload status of the body if we measure the liver iron concentration or the myocardial iron concentration. This is the normal and the abnormal values of LIC and MIC we use. It's been noted that the T2 star is measured in milliseconds, and LIC is measured in milligram iron per gram dry weight. It's severe when it's less than 1.8. Regarding the cardiac MIC is severe if it's less than 10. Rate of iron loading, it's an important thing to be measured, which is abbreviation is ROIL. It's important to be detected. ROIL is measured in milligram per kg per day. Usually, if the ROIL measured is measured from 3 to 5 milligram per kg per day, it will require average doses of chelation. While if we have extreme ranges, that's to say if it's less than 2 or more than 5, then this will require a dose adjustment accordingly. This is the formula we can calculate ROIL by, depending on the units of blood transfusion, weight of the patient, and the days over which the blood was administered. Back to our agenda, how we can treat iron overload. Usually, we give chelation to decrease anemia and ineffective erythropoiesis, to avoid complications of iron overload, and chelation significantly improves the myocardial T2 star. We start by standard monotherapy of treatment. This depends on the underlying diagnosis, patient age, the ROIL level, and the current body iron load and distribution. We have 3 licensed chelating drugs and formulation: desferrixamine, deferriprone, and defrazirox. This table represents the four types of chelators. The last two is the Difrazirox XJ type and JNU type. The box is highlighting the dose frequency, the initial dose, and in case of chronic iron overload, how we can use it. The last approved one is the JNU, the Difrazirox JNU. We have different doses in case of non-transfusion dependent and transfusion dependent thalassemia. This is the chelator we are using for our patients in the clinical hematology clinic. It's used once daily and with a dose in transfusion-dependent thalassemia 14 milligram per kg. In non-CDT we use a dose 7 milligram per kg. Actually, when we started using JNU, the patient adherence to the drug increased because it has a lower complications than other drugs we previously were administrating. TDT patient should start iron chelation therapy after 10 to 12 transfusion or when the serum ferritin more than 1000 on at least 2 occasions. But in case of NTDT, we have to start iron chelation لو الفيرتين عندنا more than 800 microgram per liter or liver iron is above 5 milligram per gram dry weight. Back to our patients, we have 119 patients on chelation, 11% of them on tiferoxamine, 35% on diferebrone, and 54 on Difrazirox. How to monitor chelation therapy? Actually, almost the three chelators, before starting, you have to perform a CBC, basal creatinine level, basal liver function test, and then after the first month, we have to weekly perform sometimes creatinine and liver functions, and then we perform it on monthly basis later on. However, in case of diferebrone, we have specifically to assess the neutrophil count because it causes neutropenia in some patients. In this case, we have to stop the diferebrone administration. Intensifying monotherapy chelation. This is required when liver iron has accumulated to concentration when liver damage may develop, that's to say more than 7 milligram per gram dry weight, or when myocardial iron has accumulated to abnormal levels, T2 star less than 20 millisecond. Emergency intensification is required when there is an evidence of cardiac decompensation, that is to say left ventricular ejection fraction less than 56%, or there is a higher risk of this occurrence, that is to say the T2 star is less than 8 milliseconds. It's not less than 10, but it's less than 8, that is to say it's a moderate myocardial iron concentration high, but it's giving us a highlight or a red flag that it may have a risk for development of a clinical severity and myocardial iron load is high. Intensification with combination therapy. At this point, there is a failure of a monotherapy and the intensification of monotherapy to produce the target results we want, or we cannot start the monotherapy or we cannot increase the dose of the monotherapy to a higher level as it may carry the probability of toxicity for the patient. Here we have many combinations available. We can combine diferoxamine with diferebrone, Difrazirox with diferoxamine, diferebrone with Difrazirox. Any combination is available. We have certain indication, as I said, if the monotherapy to increase the overall exposure to iron chelation when monotherapy is insufficient, our dose-dependent toxicity limits the monotherapy, and when compliance with monotherapy at required frequency is inadequate, and when simultaneous combination has the potential to synergistically increase cellular iron removal rates. Chelation in special situation, this is the last I will talk about. The renal dysfunction. In case of renal dysfunction, we use a low-dose diferoxamine and or diferebrone could be used in patient with CKD prior to dialysis. Once the patient will start dialysis, I can use any type of chelator in low dose with close monitoring for toxicity. In case of liver failure, all three chelators could be considered in patient with raised transaminases if the child was class A. In case of child C, we cannot use any chelation. In case of diferoxamine, could be used and it may benefit liver function both rapidly. And in case of Difrazirox, it could be used but provided that the child is class A or class B and it's contraindicated in child C. In case of cardiac complication, deterioration, if there is a deterioration left ventricular ejection fraction, we should start chelation. Here, the iron overload related acute heart failure is a medical emergency, require IV deferoxamine by a dose 50 to 60 milligram per kg as a continuous 24-hour infusion with no interruption in therapy. With deferobrone could be added to this regimen on previous exposure and associated side effects. This is my references. Thank you.